All right, folks. Can you all hear me? Thumbs up if you can hear me. Excellent. So I think we've got everyone back from their breakout discussions. And so we'll have our larger group discussion about what we've learned. And I've been told that we have more time than anticipated for this block of time. So we can certainly open it up to a much larger discussion. And if you have pressing questions or other related topics that you'd like to discuss, please do chat it in. So we're going to go around to each group, and that one person who's been designated will share with us what was the key takeaway from your discussions with the group. And then for others, please feel free to chat in. What are some of the obstacles you might have encountered in doing the work related to that specific key driver? Even if you were not in that specific breakout group, if you have some experience related to it that you'd like to share, or have a question answered by the sort of expert of that key driver, then we can do that during this time as well. All right, so let's start with prenatal engagements.
So my oversight, I forgot to ask someone to volunteer to share, so I guess I will take that on. I'll just summarize. First of all, I think it was a nice discussion. We had a variety of people representing different parts of the state, as well as different aspects of care. So I think that really led to a rich discussion. Just a couple of the take-homes that we focused on. One, there was a lot of discussion about the inconsistency in prenatal screening for mothers. So even starting before prenatal counseling, how are we identifying women with substance use or substance use disorders? So there was a lot of discussion about that, still very, I think, inconsistent throughout the state, as well as even within a system. So there are a couple of examples people shared that, you know, different OB practices will do it differently. Some are using written screening tools, some are using verbal screening tools, and then some, it's highly variable. So that was one thing we talked about, and one thing that Illuminate and CPQC, I think, are very interested in looking at incorporating universal screening for substance use as part of their work. So I think that'll be a huge help, but again, a challenge. Other things we talked about as far as successes for prenatal screening, people mentioned, you know, obviously having an OB leader, OB partner, and then regular meetings to discuss this. So it's on the forefront of everyone's mind, and then figuring out how to incorporate screening and counseling into otherwise busy obstetrical practices, and also a lot of challenges still, concerns on the behalf of providers with creating stigma by just asking about substance use, and then having women less or more reluctant to return for care. That's kind of a brief overview. I don't know if anybody else who was in the discussion has anything else to add.
For those on the phone, feel free to chat in, or even, you know, unmute yourself. But what has your experience been like around prenatal engagement? You know, Danielle and her group highlighted some of the facilitators and barriers. But first of all, are you experiencing what Danielle has shared? And do you feel that you've had success in engaging prenatal providers? Because I think overall that continues to be a struggle for us at CHoSEN Quick more globally. So there's a question from Blair. She asks, Danielle, do you think it's important that all providers use the same type of screening tool, or is it just important that it's done?
I think, and I mean, if any of the other, or Ryan or someone wants to chime in, but I think my own, I think it's less, there are different screening tools that are available. I think it's less important that the same one is used, but that one is used. I mean, there are some that are validated for different populations, and I think all are probably, but again, I'll defer to Ryan or other people who have more expertise in that. I think all would be, if you're using a validated tool, I think that's adequate. I think the first challenge is just making people aware of the importance and necessity of universal screening, because I think it helps really eliminate stigma. Like, it's just something that as part of your prenatal care, you're going to be asked about. And so if you're doing it universally, I think that does go some way to decrease stigma. The answer is no. I think as long as everybody's using a tool, and the different tools may incorporate better into their practice. So whether you prefer to do it, verbally based on your workload, or if it's better to do it, with just a written form. Who does it also varies. I know universities shared that social workers may take on that role, so it doesn't even have to be the obstetrical provider or the prenatal provider who does that.
Yeah, I would agree with
And
that entirely from what we talked about, is that we just need to know. I don't really care what tool you use, but we need to know, and the pediatric provider needs to know. And the earlier we know, the more we can help these women, as was highlighted by Dr. Shipp. The earlier we know, and this is a great point for intervention and motivation, the more likely we are to have a better outcome. There is an interesting article that was published in the Journal of Addiction Medicine the past 2 months that they looked at OB providers and they trialed different tools, and basically it was which one came out more preferred, and that was the 4 Ps. And I think it's because it gets at multiple things in pregnancy and has been validated for pregnancy. That being said, I don't think that's the tool you have to use. If, as Danielle highlighted, your workflow is different, find the tool that gets the information you need. At St. Mary's, we're currently looking at using a different tool. And so you just got to find what works in your system and get that information.
It looks like we have a few more questions for Ryan, if you wouldn't mind. Questions posed by Erica. She asks, how do you approach the frequency of screening for substance use disorders? And how can we be sensitive to mothers whose perception is that we just keep asking?
Sure. I think that I have read great data that says this results in better outcomes if you follow this protocol. There are professional opinions that would say that we should be screening at least at the beginning and towards the end of pregnancy, like we would for other high-risk conditions in which we would do laboratory screening. But there are other groups that would say that it should be done once a trimester. So I think the frequency depends on the relationship with the patient, but I would say that a minimum of twice in pregnancy, like we do for risk of Hep C, HIV, hepatitis, and other things, I think makes clinical sense to me. As far as how do we be sensitive, I think Danielle highlighted a point that this really needs to be just adopted and seen as something we do for everyone. We are not doing this as a judgmental point for you because you look, quote unquote, like someone who uses substances. That would be the worst approach we could take. We really need to make sure that it's a universal screening. And as we introduce that screening, just like we would for other things, we say this is something we do for everyone. And I'm just going to ask you these questions. And if it's a current concern, just know that we're here for you and we can help with these issues. And you might link it into other things. And that's why people like the 4 Ps, is because it gets at other things as well, like domestic violence. And so it's not just a standardized, now we're going to talk about substance use disorder. It's an escalating screen by condition.
Great, thanks, Ryan. All right, let's move on to our next group, breastfeeding.
Hi. So similar to Danielle, we had a great group that represented a lot of different people within our collaborative, from the Western Slope, from Pueblo, Colorado Springs, Fort Collins, and people's varied backgrounds in regards to their roles in the care for these moms. We had a great discussion. I would say very similar to what Danielle presented is that we identified very similar challenges across the spectrum of everybody's experience, which included how we sort of divided it down was sort of like hospital level factors, which included the challenge of the continuity of care going from prenatal to L&D to postnatal care, and how we have consistency across that spectrum. And then another challenge of provider and staff education and consistency. So those were some of the challenges that were consistent from a hospital level overview. And then we also identified that from a patient level challenges, that we had variations in maternal intent, variations in mothers' eligibility and how we determine that eligibility, and then support for mothers once they're discharged from the hospital was really highlighted by one of our team members, and that was really eye-opening for us. I think some of the while we had several different challenges that we identified, some of the pearls that we took away from that conversation that people are doing is providing consistent education. One of our team members shared that they had rolled out a survey to sort of in their own institution that encompassed all different staff members and providers. And then within the survey provided some questions about, the guidelines and what the recommendations currently are. And then within that survey, it provided answers or sort of the correct answer to the question. So not only was it an assessment of the gaps of knowledge, but also provided some education. So we found that to be really useful. And then another one of our team members shared all of the extensive work that they do in providing prenatal breastfeeding education and counseling. So separate from necessarily the prenatal consult that we would do for a mom who's identified as having an opioid use disorder, but to really promote safe breastfeeding early on from the very beginning of pregnancy, and really collaborating with that prenatal consult. Another area that I would say just for the whole group to be aware of that I found was interesting was how do we really educate and provide more information to our collaborative partners like social services, our residential treatment facilities. How do we provide more education and outreach education about the importance of CHoSEN's work in general, but also in supporting safe breastfeeding for these moms after delivery.
Great, thanks, Erica. Other questions or comments? For those on the call, sorry, go ahead.
No, I was just thinking, and this thought just came to me, Erica, within the providers education work group, recently I had the opportunity to participate in one of the family advisory board meetings, and it was so powerful to do that. And one of their requests was that they have the opportunity to share their experiences with this larger forum. And I would imagine that they talked a lot about their experience just with communication and the screening practices that they've been exposed to. But I think also their experiences and decisions regarding breastfeeding, to hear that directly from family advisory board members at one of these forums might be really powerful for all of us, as well as out into other, and to use that as a starting point, but then perhaps that format as we reach out into the community and share this education to truly hear from them might be really powerful for our peers and providers.
That's a great idea, Carol. Thanks.
All right, let's move on to non-pharm approaches, ESC.
Hi. Okay. I apologize. My internet connection has been kind of going in and out. So hopefully we'll stay connected here. So I had a smaller group of participants in my breakout session, which was great because we could really delve into some of the challenges that one of the units is having. So we were speaking with one of the nursing staff providers at St. Mary's.
Oh, did Colleen's audio go out for the rest of you? Yeah. All right, Colleen, you might have to go to a different part of your house. So we'll come back to ESC, okay? Let's move on to plans of safe care. Annie?
All right, hi. So for the plans of safe care, I would say we had sort of a moderate size group, and we talked a lot about what plans of safe care means and how that implementing the plan of safe care might be a little different for every hospital depending on their workflow. But we reviewed what the important elements of the plan of safe care are, not only for CHoSEN Quick, but also just in the broader sense that, every baby who's exposed really to any substance by law requires a plan of safe care. We also talked about that transition, and I think that's the thing that's so important about the plan of safe care is it really serves as the biggest transition from the inpatient to the outpatient care of the family, not just the baby but the family, and how we can do better. And we talked about the data that you presented early on, and how since implementation of CHoSEN, we really have seen a nice increase in EI referrals, which shows that we're really trying to pay attention to the fact that these are high-risk babies who are at risk for developmental issues down the road. But where I think we're not doing a great job, and it seems surprising, is with our PCP handoff. So we talked about how we can improve that with the plan of safe care. But then we also spent some time talking about that inpatient to outpatient transition, and how, ideally we would be able to, give every family a document and that says, this is your plan of safe care, and you can take this to your PCP and your caseworker. And that doesn't always happen for a variety of reasons. But through the county intake, workers, we're going to have and that's something that we're working on through the Colorado Steering Committee. But if there isn't a plan of safe care, once a family is referred to the Department of Human Services or Social Services, that all of our county intake workers will be able to develop one through their intake too. So there are kind of two ways to approach the plan of safe care. And then we also talked about how through CHoSEN we're going to be updating our red cap questions so that we can really delve into the kind of more specific pieces of the plan of safe care. And I think that may also facilitate hospitals' ability, hospital, your thoughts or your approach to developing this at your particular hospital. We didn't have too many people talk about any specific barriers that they've had. And so in our particular group, so if anyone else on the larger group has questions, I'd be happy to address them.
Thanks, Annie. Questions or comments? Hey, Annie, one of the questions that we've gotten from folks, both in healthcare and outside, where does the plan of safe care live? Like, how would one access it? If a family in fact has one that ideally was created early on, how do we know about it?
Well, so that's I think that's one of the sticking points, is that, ideally, yes, we would have a physical document that would travel with the family, and that they could take with them to their various appointments, and that's something that can be tracked also through DHS, as far as a record that, yes, this family has this plan of safe care. What we're finding is that that's a little bit more difficult, the reality of that, because I think that's where every hospital is kind of unique in what their workflow is and their ability to document this. Many of the elements of the plan of safe care are being done already as just part of a discharge of any baby, especially a high-risk baby. And so one thing that we've been talking about at Poudre Valley, for instance, is how can we document this without creating like a new job for any one particular person. And all hospitals have different resources as far as who's responsible for this plan of safe care. So I think what makes the most sense is that these elements are included in a discharge summary, and that it would be a discharge summary that's specific and includes these elements. And I believe that the actual plan of safe care document is on the CHoSEN website in the toolkit area, but we also, if you want that document, we can provide that too.
Great. And there's a question you're asking: have there been discussions with related to educating or communicating with DHS social services regarding plans of safe care?
Yes. So through the Colorado SEN Steering Committee, my co-chair is Susie Morris, who's on here, and she really is that link. And if any of you participated in the kickoff event that was March 2nd, I think Jade referred to it as probably the last time everybody was in a big group. That's really what our focus is now, is that link between you know, having this discharge summary, this discharge plan from an inpatient standpoint, but that handoff and how we can hand that off so that DHS and social services has that plan of safe care. So right now, COVID has sort of messed up the initial plan, because the initial plan after the kickoff event was that we were going to go out to all the counties, all the participating hospitals in CHoSEN, and then all the other counties too, to make sure that everybody is educated about the plan of safe care, and that, you know, the people who are doing the intakes, that they have, there's a web-based training through Illuminate, and that they're educated on how to create this plan of safe care if there hasn't been one, and we can address that. Now that there is no traveling anymore, Susie's in the process of sending out a survey to all of the hospitals and counties, and trying to assess where people are as far as plan of safe care, and then we can ideally set up, you know, a virtual session with, you know, with the various counties and such, to educate them on this and see if we can get things moving forward from a virtual standpoint.
Hi, this is Susie. I also wanted to add, thank you, Annie. That was a really great summary as far as our work here in child welfare. One thing I wanted to add, because this is such a great question, is that while right now our caseworkers are not required to complete the plans of safe care, our child welfare statute and rule will reflect, more than likely in this next year, that child welfare caseworkers, when SEN is identified as the call-in reason, will be required to complete a plan of safe care if one has not been completed. And the assessment, they will not be able to close their assessment without one being completed.
That's good to know, Susie. Thank you. We have a few comments here in the chat. Looks like there's some concern about that physical plan of safe care traveling with families seems like a lofty goal, as many families will lose or throw away most papers that they receive from the hospitals, and just emphasizing the importance of this warm handoff, having this transfer of the plan from provider to provider that's not necessarily dependent on the family bringing it from one to the other.
Yeah, I think those comments are completely valid, and I think that's what we've found, you know, in trying to implement this practically in the hospital, is it more important that there's an actual document that they have, or is it more important that that they have a PCP, that there was referral, that all the resources for the caregiver are made, that the caregiver has education, and it's, meaning that all of the things that we have on our checklist, that those things are done and documented somewhere. And I think, especially for all the hospitals participating in CHoSEN, I think once we update REDCap, that's going to be nice too, because then as you're filling out your data, those questions will ideally be there. Was this done? Was this done? Was this done? And one thing we're doing at Poudre Valley, we have a nurse educator who, we've had some issues with, just making sure that now that so many babies are not, their length of stay is decreased and they're not receiving morphine and they're not coming to the NICU, that all of our pediatric colleagues and out on our level 1, where these babies mostly are staying and not staying as long, that they're educated to know that these things need to be done with these babies. And so I think that education is going to help, and then through CHoSEN we'll be able to monitor whether or not these things are being done, and hopefully at the next forum we'll be able to report back to you.
Great, thanks so much, Annie. And I think we got Colleen back. I see your video is clearer than it was earlier, and so we'll have you share what your group discussed related to ESC.
Okay, great, thanks. So we had a smaller group. We had actually a couple social workers join, and then we also had a nursing staff provider from St. Mary's in Grand Junction join, and we were able to really delve into some of the barriers that they're having and how they could solve that. And this is something I think that some other units may have run into as well. So they've been practicing the ESC model of care for probably close to 2 years now. And what they found is that putting these babies in the NICU when they need medications isn't the best environment for them, because they're not able to have a private space. And so they're just now able to move these babies over to the pediatric unit, and that's going to be the new norm for them. With that change, it'll now be the pediatricians who are managing these babies who need medications instead of the neonatologists. And then just working through how that change will look and who can bridge that gap in terms of when a baby is really struggling at night. And so we talked about utilizing the NNP team to be the team member to help bridge that gap, and how that practice change can be presented in a manner that is accepting. And what we've come up with really is that it's a lot of ongoing communication and also education for the staff as well. I shared with her some experiences we've had at our unit where we actually now get a little bit of a sign out from a pediatrician if there's a baby in the well baby nursery that they're worried about, who's having withdrawal symptoms that we might hear about overnight. And that actually has helped even the nurses to be able to be more willing to call us at night and not be so afraid of waking a sleeping provider to let them know about a baby that's really struggling. And so just talked about those key points that could be put into a protocol that they're getting ready to present to the pediatricians. And really just our pearls are just emphasizing the ongoing education. There's plenty of units who've been using ESC for quite a while now, but just some issues that come up, things that I even mentioned in my survey about when exactly do you do a team huddle? When exactly do you start meds? Or when a baby is on medications, how do you go about the weaning process? And how case reviews of infants is actually a good way to know where your barriers are and what sort of education is needed. So that's what we came up with.
Great, thanks, Colleen. Questions or comments? Curious to know if for the participants on the line who have ESC in place, how often do you have family members participate in the huddles? What's your experience been like? So these huddles ideally are supposed to happen. Families are going to weigh in on whether or not the infant can be can be fed, can sleep, can be consoled, and whether or not families are weighing in on, is it time to treat pharmacologically?
At Memorial, when a baby is at risk for withdrawal, there is a huddle at admission to the postpartum unit, and then families can request it at any time. And if the baby reaches a place where we need to make a decision about escalating treatment and transferring to NICU, then we have it again.
That's awesome. So you have the team that actually go to the postpartum area to meet with the mother?
Yes, we go into mom's room. So she's there. Obviously, the baby's there. The provider is there. The charge nurse is there. The primary nurse is there. Social work is there.
That's terrific. In this COVID period, that makes me a little nervous. That's a lot of people, but in general, I think that should be definitely the plan.
In COVID period has changed everything. We are all wearing masks for patient-facing care, and we distance ourselves in corners of the rooms to be able to make sure that everybody is as safe as they can be.
Great, thanks so much for sharing that. All right, let's move on to the last breakout session. This was dissemination and publication, and we've got Megan who will share with us.
Yeah, hi. So our group kind of talked about how you're going to share the information that you gather. And I think it definitely depends on whether you're writing an academic paper or you're talking to your C-suite or even the local news. And so I think the important takeaways from Susan was to really think about your audience and think about what's important to that audience, and then modify your message for that. And so kind of specifically a takeaway that I'm walking away with is Susan had mentioned, it's a lot easier to get OB-GYNs and prenatal care on board with how we're going to care for the substance exposed newborn if you really focus on the improvements in maternal mortality and complications after delivery if you're not involved with the SCN project. And so I think that's kind of important. I think as a pediatrician, I just assume everybody cares about the babies the most. But I do think maybe I'm really focusing on the moms when talking to OB-GYNs, because that's absolutely their passion and what they chose their specialty for.
Great. Thanks so much, Megan. And we unwillingly or willingly, I'm not sure what the right adjective is threw Megan in there to be our representative. Other questions or comments?
I like that term, voluntold.
And I'll add, I think the few other takeaways that we took away is that if you, your group, your institution recognizes that you're doing the work and you have results that you want to share with a certain audience, but you're not sure how to package it. How do you make it appealing to a specific audience? Just reach out to us, I think was a big takeaway. Between the university, Illuminate Colorado, and CPCQC, there is plenty of expertise and bandwidth to help you in communicating that. So you can imagine that if your site has these awesome outcomes, so like I'll use Parkview and Memorial as an example. They have terrific results, and they've combined their results into one, and we worked closely with them to write a peer-reviewed manuscript. And so that's sort of more of a scholarly audience for a peer-reviewed publication. But say you're trying to convince your C-suite that this is worthwhile, that there's got to be some financial investment that's made for your team to continue this work. Well, that packaging and that presentation of CHoSEN and results is going to look real different than in a scholarly paper. Lastly, you're having a hard time getting your prenatal providers engaged. And exactly as Megan said, you're going to have to put up a few slides on maternal opioid substance use disorders or overdose being the leading cause of maternal mortality, and that those deaths are not happening in the immediate postpartum period, but in fact are fairly equally distributed in that first year of postpartum. So there's got to be a few slides that really focus on mom. And so we have all of those resources, between the three organizations. And so I would say the take home is please reach out to us and we can help you sort of fine tune and prune your message for the right audience. All right, so that wraps up our breakout discussions. If there are no further comments or questions, we're going to move on.